Hi, everyone. We're going to get started in just a moment. Welcome to the webinar, Report Back from San Antonio Breast Cancer Symposium with a spotlight on metastatic breast cancer. I'm Christine Benjamin, the Senior Director of Patient Services and Education. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 44 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Iyengar finishes presenting, we will begin the Q&A discussion. You're welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. The webinar is being recorded and will be available on the SHARE website soon. I'd like to introduce our speaker. Dr. Neil Eingar is a board-certified medical oncologist and physician scientist at Memorial Sloan Kettering Cancer Center, where he specializes in the care of patients with breast cancer. He also holds joint research appointments at the Rockefeller University Center for Clinical and Translational Science and Weill Cornell Medical College in New York. Dr. Iyengar is a National Cancer Institute-funded principal investigator and an American Cancer Society research scholar. His research program focuses on the use of metabolic interventions such as exercise, diet, and cardiometabolic medications to reduce cancer risk and improve response to cancer therapy. He has been the lead author of multiple articles published in leading medical journals, and he's received grants and awards from several organizations, including the Breast Cancer Research Foundation, Conquer Cancer Foundation, and the American Society of Clinical Oncology, among others. Dr. Iyengar, thank you so much for being here. We really appreciate it, and it's so good to see you again.
My pleasure, and thank you for, good to see you, and thank you for that lovely introduction. We were just chatting before everyone came online, and I mentioned that I think the last time I had the privilege of doing this was 2 years ago, and that was in person. And so while I can't see any of your faces, and it feels a little odd speaking to my computer, I trust that everyone is there, and I look forward to having a discussion with you all. I'm going to spend maybe about the first 40 minutes or so really highlighting what I think were some of the key advances that came out at San Antonio this year, and then open it up to questions about the research and about some of the recent therapeutic options that have been presented. And, you know, I'm gonna really just sort of talk because I think that's gonna be more helpful in thinking about the broader treatment of breast cancer than for me to show you, you know, specific data on slides. Because what I'd like you all to take away from this is where the field is as a whole and where we're going. So I hope you find that helpful. I've kind of broadly outlined what I want to speak about into 3 categories, and this is a focus on metastatic breast cancer, so we'll be talking primarily about that category. But with the data that came out at San Antonio this year, you can't really talk about 2020 San Antonio without talking a little bit about some of the big studies that came out in the adjuvant setting or for primary breast cancer. When I say primary breast cancer, I'm referring to non-metastatic breast cancer or stage 1 through 3 breast cancer, just to be very clear. So we'll spend a little bit of time on that so I can highlight those major studies. Then we'll move to metastatic breast cancer, and I'll focus, of course, on the 3 classical phenotypes or types of metastatic, of breast cancer in general, and that is hormone receptor positive, HER2 positive and triple negative breast cancer. And then, as you just heard, my own personal research interest is understanding how we can enhance or optimize our metabolic health, our metabolism, to really improve treatment response to breast cancer therapies, whether that's in the prevention space, whether that's in the adjuvant space, or whether that's in the metastatic space. We're learning a lot. And in fact, there was so much research in that area of improving metabolic health, whether it's through diet, exercise, or even medications like diabetes medications, that there was a whole session at San Antonio this year that was dedicated to that area. And I had the pleasure of presenting the work of 5 other research groups that was presenting updated data at San Antonio this year. So I'll share some of that with you towards the end. So that's kind of the general overview of what I hope to accomplish today. And so let's get right to it. Let me also just put in a plug that I hope everybody is staying safe with all of the craziness of this year. Obviously we've got some hope coming down the pipeline with regards to the pandemic. For those of you that are in the Northeast, I hope you're all staying safe in this blizzard on top of everything. So let's get started with adjuvant therapy. The major advances that came out at San Antonio with regard to primary breast cancer have to do with the Rxponder trial, and that's the use of a genomic test, also known as the Oncotype score, for women who have lymph node positive breast cancer. So that's one trial that I'll talk about. And then the other area in the primary breast cancer setting that had some major data at San Antonio this year were with regard to Cdk46 inhibitors. And as those of you who are familiar with metastatic breast cancer, as those of you know, those drugs, those Cdk46 inhibitors, are molecular therapies that are used in combination with hormone therapy for the treatment of metastatic breast cancer. And there has been a lot of recent investigation, large clinical trials dedicated to understanding whether or not those drugs are useful for patients with primary breast cancer. And as you'll hear me say, when we get into those trials, is I actually think that some of the knowledge that we've gained in the primary breast cancer space with regard to using Cdk46 inhibitors has actually informed our use of those drugs, or will inform our use of those drugs for people with metastatic breast cancer. So it's a continuous landscape that we're talking about here. So let's start with Rxponder. That is the large clinical trial that used the Oncotype test to determine whether or not women with hormone receptor positive breast cancer, stage 1 through 3, and having positive lymph nodes, if those women benefit from using chemotherapy or not. Let me give a little bit of background information on that. As many of you may know or may not know, when a person has been diagnosed with primary hormone receptor positive breast cancer, obviously the mainstay of curative therapy is to remove the cancer by surgery. And also oftentimes radiation to clean up any remaining cancer. However, the problem is if microscopic cancer cells or circulating tumor DNA has escaped the tumor from the breast before the surgery has happened, before the tumor's been removed, that microscopic cancer can get into the lymph nodes, it can get into the bloodstream, it can get into any part of the body really, and it can lay there undetected and dormant. And we can't see it on a scan. It's too small to be seen on a scan. That is what eventually causes recurrence in metastatic disease. And that is the rationale for giving systemic therapies like hormone therapies or chemotherapies before or after surgery in order to eradicate that circulating disease. Now, of course, it's not 100% success rate. It is possible that that circulating microscopic cancer can be resistant, either it's already resistant or it becomes resistant to those systemic therapies. And so despite the use of those systemic therapies, metastatic disease can still develop. Nonetheless, clinical trials have shown us over the years that these systemic therapies are on average successful at preventing the continued growth of that micrometastatic disease. So there's a lot of research that's being done right now on whether or not we can detect whether that micrometastatic disease is present. And you may have heard of circulating tumor DNA. ctDNA is something that we're investigating for people with metastatic disease, and that is because when you have breast cancer, whether it's a tumor in the breast that hasn't yet been removed, or if it's a tumor elsewhere in the body that's breast cancer, that tumor is constantly shedding its DNA into the circulation. And we've now learned that we can differentiate that DNA from the tumor, that's circulating tumor DNA, we can differentiate that from the normal DNA that's floating around in our system. And in the metastatic setting, measuring that circulating tumor DNA may be helpful in understanding how the breast cancer is behaving. Is it getting ready to progress? Is it developing new mutations? It's still somewhat early days in terms of the use of circulating tumor DNA to measure treatment response, but a lot of work is being done in that field. Similarly, we're now trying to decide, can we use that approach of measuring circulating tumor DNA to help us risk stratify people with primary breast cancer? What is their risk of recurrence? Or even to determine whether or not we should be escalating or de-escalating treatments for people in the primary breast cancer space based on their circulating tumor DNA profile. Now, in that setting, it's really, really early days. We don't know if it's helpful or not. And there is research going on in that area as well. And the reason why I say it's really, really early days is because you can imagine for somebody who has metastatic disease, you can see it on the scan, there usually is some amount of detectable circulating tumor DNA. For somebody with primary breast cancer, where you can't necessarily see whether or not they have tumor elsewhere in the body, you have to have a very, very, very good test to detect very tiny amounts of circulating tumor DNA. In other words, if I draw somebody's blood, this is also known as a liquid biopsy. If I draw 2 or 3 vials of blood, or even 3 or 4 or 5 or 6 vials of blood, and I look for ctDNA, circulating tumor DNA in those vials of blood, well, that's a minuscule fraction of the total blood volume in our body. So it doesn't rule out the possibility of circulating tumor DNA in other parts of our body. And that's why that kind of testing or that kind of approach is not ready for prime time, certainly not in the primary breast cancer space. We're getting there in the metastatic space, but not there just yet. So what can we do in the meantime? Well, in the meantime, we can look at traditional characteristics of the tumor, how big the tumor is, how many lymph nodes are involved, to give us a sense of what is the risk that there is circulating tumor DNA or that recurrence will happen. The estrogen receptor status is also helpful. The grade is also helpful. And for people with hormone receptor positive breast cancer, we have also found that looking at the expression of genes in the tumor can be helpful as well, because it tells us, is the tumor biologically programmed to metastasize? And that is what tests like the Oncotype score does. The Oncotype is a genomic assay that looks at 21 genes. These genes are involved in tumor invasion and tumor metastasis. And it tells us, is the tumor genomically programmed to travel? It also tells us if the tumor is susceptible to chemotherapy. And so for women with hormone receptor positive, stage 1 lymph node negative breast cancer, doing the Oncotype testing is basically a part of the standard of care. We almost always do it. Unless the tumor is teeny tiny, less than ½ centimeter, we almost always do the Oncotype testing. And if it is a high risk score, that tells us that the tumor knows how to metastasize, and we should escalate our therapy and use chemotherapy followed by hormone therapy to try to lower the risk of metastasis. Now, the big news about a year ago, or might actually 2 years ago now, was that we used to say that if you have a high risk score, you need chemotherapy. If you have a low risk score, you don't need chemotherapy. If you have an intermediate score, we don't know. And most of us would err on the side of caution, and we would use chemotherapy in that intermediate setting. Well, as many of you may have read in the news, the TAILOR-X trial was the next large trial that looked at intermediate risk scores for the Oncotype test, and found that for postmenopausal women, if your score was lower than 25, which is the low risk range and now getting into the intermediate risk range, you didn't benefit from chemotherapy. So that dramatically changed our treatment approach, and now we can spare a lot of women with lymph node negative breast cancer from chemotherapy. Now, if you were premenopausal and you had a score between 16 and 25, there was still a bit of a question mark, and we're still discussing using chemotherapy in premenopausal women lymph node negative with a score of 16 to 25. So the Rxponder trial builds upon that and says, let's take it one step further. What if you have stage 1 through 3 breast cancer, hormone receptor positive, and it does involve your lymph node? It involves 1 to 3 lymph nodes. That's the key distinction. If there's more than 3 lymph nodes involved, that person would not have been eligible for Rxponder. They would have gotten chemotherapy in most cases. But what about these folks with 1 to 3 positive nodes and hormone receptor positive breast cancer? So what the Rxponder trial did was it checked the oncotype score. If your score was 25 or below, you were randomized to chemotherapy or no chemotherapy. And essentially, there was some fancy statistical designing. So if you actually look at the trial and read the study results, you're going to see terms like interactions and whether the predictive hypothesis was met or not met would determine whether or not the prognostic hypothesis should be examined. I'm just going to distill all of that to tell you the bottom line. The bottom line was that for postmenopausal women with hormone receptor positive breast cancer stage 1 through 3 with 1 to 3 positive lymph nodes, if the oncotype score was 25 or below, there did not appear to be a benefit of chemotherapy. And so that is very much practice changing, because we generally err on the side of offering chemotherapy if a lymph node is involved. What this is telling us is that doesn't appear to be helpful. And so now the practice is changing such that we're not necessarily recommending chemotherapy for that group. Now, somebody asked me very astutely, one of my patients asked me very astutely, well, if the cancer traveled to the lymph node, doesn't it mean it knows how to travel? That is possible, but it's also possible that the cancer cells simply drained to those lymph nodes from the breast and kind of traveled there through the drainage stream. And the oncotype score is a genomic test, so it helps us make that distinction. Was the cancer genomically programmed to travel, or did it just kind of get there? And these results would suggest that if the score is low, less than 25, even if it got to the lymph nodes, it's not going to get much further. Or if it is going to get much further, if it is going to continue to travel, chemotherapy is not going to stop it, but hormone therapy will. So that's the key finding for postmenopausal women. For premenopausal women, it gets a lot more murky. And in the premenopausal setting, if there are 1 to 3 positive lymph nodes, it looks like chemotherapy may still provide a small benefit. And so for premenopausal women, the practice is not really changing, at least not yet, where we're not willing to say, okay, you don't need chemotherapy, because based on the Rxponder trial, we cannot rule out a benefit. In fact, there appears to be a benefit of chemotherapy for premenopausal women with 1 to 3 positive nodes. So that was the Rxponder trial. That was kind of the big news in the primary breast cancer setting. The other trials in the primary breast cancer setting that I need to mention are with regard to Cdk46 inhibitors. And so many of you are familiar with the 3 Cdk46 inhibitors that are approved for the treatment of metastatic hormone receptor positive breast cancer. That's Palbociclib, that was the first CDK4/6 inhibitor to be approved, and then Ribociclib and Bemecyclip. And many of us have felt for a long time that these 3 drugs are very similar, and if not the same, because in the trials testing these drugs in the metastatic setting, the Paloma trials, the Mona Lisa trials, these trials essentially all showed very similar results, that these drugs were very effective. We're all very excited about the CDK4/6 inhibitors for prolonging progression-free survival and overall survival when combined with hormone therapy. And the magnitude of benefit seemed to be very similar amongst the 3 drugs. They're each a little different in terms of side effects. We know, for example, Bemecyclip doesn't suppress the blood counts as much. It does, but not as much as Ribociclib and Palbociclib. But on the flip side, Bemecyclip tends to cause more GI side effects like diarrhea than Palbociclib or Ribociclib. Ribociclib is the only one of the CDK4/6 inhibitors that has a clinical trial specifically dedicated to premenopausal women. That's the MONALEESA-7 trial. The other two CDK4/6 inhibitors, they did have premenopausal women enrolled on some of their trials, but those were trials that mostly included postmenopausal women. So if you're a data purist, you would say that ribociclib has the most data for premenopausal women. It has been shown to have an overall survival benefit. In other words, it prolongs the life of premenopausal and postmenopausal women with metastatic hormone receptor positive breast cancer. And so for many of us, including myself, ribociclib is my CDK4/6 inhibitor of choice for premenopausal women. For postmenopausal women, they all seem to be similarly effective. However, we're now learning that there are some differences when we start thinking about bringing these drugs in earlier. So the question has been lingering for some time about whether or not, since these drugs are so effective for people with metastatic breast cancer, should we be offering these drugs earlier to try to reduce the risk of developing metastatic breast cancer? And so all three CDK4/6 inhibitors have launched trials testing the combination of hormone therapy, which you would normally give in the adjuvant setting for primary breast cancer, but now adding a CDK4/6 inhibitor. And at San Antonio this year, 2 of those trials were reported. And just to provide a little more background, one of the largest trials, the PALLAS trial, was reported before San Antonio, and it was a combination of palbociclib with hormone therapy as part of adjuvant therapy for patients with primary hormone receptor positive breast cancer. And it was a big trial. We participated in the trial. And unfortunately, it was a negative trial. There did not appear to be a benefit of adding palbociclib to hormone therapy to reduce the risk of metastasis for women with early stage hormone receptor positive breast cancer. Now, the problem with that trial is there was a high rate of discontinuation. A lot of people stopped the palbociclib either because of side effects or because it was suppressing the blood counts. And so we thought that perhaps it was the discontinuation rate that was contributing to that lack of efficacy for adding palbociclib. So we all awaited the Penelope trial, which was reported at San Antonio. And the Penelope trial focused specifically on people with non-metastatic breast cancer, but higher risk breast cancer that was more likely to become metastatic, either because the lymph nodes were positive or other biological features that made the breast cancer higher risk. Unfortunately, the Penelope trial was also negative. We did not see a benefit of adding palbociclib to hormone therapy for reducing the risk of metastasis. And so that's 2 negative trials in the adjuvant setting for palbociclib. However, the story is a little bit different for abemaciclib. Abemaciclib is another CDK4/6 inhibitor, and that drug was combined with hormone therapy, again, for people with primary breast cancer, and there was indeed a benefit. There was a reduction in the risk of recurrence, a significant reduction in the risk of developing metastatic disease when abemaciclib was added to hormone therapy. And we saw that reported in the monarchE trial at San Antonio. And so while we are awaiting approval, I am actually, several of us are starting to offer abemaciclib in combination with hormone therapy to our patients with the highest risk non-metastatic breast cancer based on these data. There is one more trial that we're waiting for the data to be reported, and that's the NATALEE trial. That's ribociclib. So that is testing whether the combination of ribociclib with hormone therapy is effective. And I'm anticipating that that data will be reported soon, if not at ASCO, then at next year's San Antonio. So far we do see conflicting results. We see negative data in the adjuvant setting for palbociclib. We see positive data that it is beneficial for abemaciclib, and we're awaiting the data for ribociclib. What does that mean for the metastatic setting? Well, nothing to be technically accurate, but it does start to make us question, are these drugs a little bit different? You know, maybe in the metastatic setting it doesn't matter, and as we've seen in the trials, all 3 of these drugs are efficacious. but perhaps there are some subtle differences between the drugs that do matter in the primary or non-metastatic setting. The other difference that I'll add is we know that Bemecyclip has some CNS activity. In other words, it can be helpful for people who have breast cancer that has traveled to the brain. And so when I'm thinking about which CDK4/6 inhibitor to use in the metastatic setting, that's one of the first things that I think about is, does this person have involvement of the brain or the spine or the cerebral spinal fluid? And if so, I would gravitate towards Bemecyclip for that person. So that's kind of those are kind of the big trials. Of course, there was a lot that was presented, but that's the big news for the non-metastatic setting. And we'll move on now to the metastatic setting. The first thing I'll say about the metastatic setting is it's not going to be possible for me to do justice in the time that we have to all of the research that's been done. But we saw a lot of phenomenal research, both on the scientific side in terms of understanding the biology of breast cancer in the metastatic space. I talked a little bit about that when I started going on the tangent about circulating tumor DNA, but that's kind of a taste in terms of what's going on in terms of the science there. People are looking at whether or not we can profile the mutations and the biology of breast cancer by looking at circulating tumor DNA so that we don't necessarily have to go do a biopsy every time we want to recharacterize the breast cancer in the metastatic setting. Again, that's research that's ongoing. We're learning more about the tumor microenvironment and the immune cells that surround the breast cancer tumor, both the primary tumor in the breast, but also at metastatic sites. We're learning about reprogramming of metastatic disease. In other words, if there are more than one metastatic site, it turns out that the DNA, the tumor DNA, may be able to communicate with each other by traveling in little pods called exosomes in the bloodstream. And so what that means for treatment, if one tumor site, one metastatic site develops a resistance mutation and is able to start growing, how does that confer that information to another metastatic site? It might be through traveling through these exomes. So there's a lot of that is very preliminary right now, but very interesting nonetheless, because that is going to have direct implications down the road on how we approach the treatment of metastatic breast cancer and whether or not we can change the trajectory of the cancer by really understanding that biology and how the communication between metastatic sites occur, how the microenvironment plays a role in either inhibiting or fostering the growth, invasion, and metastasis of the cancer cells. So there was a lot of that biology that was presented at San Antonio this year. So our knowledge is advancing there. What I would like to talk about in terms of the metastatic space, there are a couple of big trials that I think are important to discuss here. If we first start off with ER-positive breast cancer, there's a lot of work that's being done, obviously, in ER-positive breast cancer, new molecular therapies that are coming down the pipelines. There are new types of CDK4/6 inhibitors that are being studied. There are CDK2/4/6 inhibitors that are in phase 1 and phase 2 trials that are being tested. There are new types of antibody drug conjugates that are being tested. And there are new chemotherapies that are being tested as well. And one of the big trials was the Contessa Trial. This was a phase 3 trial of Tesolizumab, which is an oral version of Taxol, which many of you are familiar with. And obviously, especially in the current era where we're trying to minimize people's exposure to one another and to the outside, an oral therapy is very attractive. So we don't necessarily have to bring in people for IV infusions. And so Tesolizumab was a large phase 3 multicenter trial, or Contessa is the name of the trial, I should say, that looked at the combination of this oral version of Taxol, Tesolizumab, plus capecitabine or Xeloda, which is another oral chemotherapy that I'm sure many of you are familiar with, versus capecitabine alone for people with hormone receptor positive metastatic breast cancer. And I should also clarify that in this particular trial, it was specifically for people who had previously gotten Taxol. And so that's important, and I'll explain why in a minute. But essentially, there was a benefit. There was a benefit in preventing the progression of metastatic disease with the addition of Tesa-Taxol to capecitabine. And so we anticipate that based on the results of this trial, many of us are predicting that the FDA will likely approve Tesa-Taxol as a new treatment option for metastatic breast cancer in combination with capecitabine. Now, the reason why it's important that this trial included patients who had previously gotten a taxane is that it tells us that the drug, that Tesa-Taxol, is effective even if a person's gotten Taxol before. In other words, we often think that if you've been exposed to one type of treatment and the disease progresses, it may not be a good idea to reuse that treatment, and it may not be, by extension, it may not be a good idea to use a drug that's related or within the same family of that treatment, because the cancer may have developed resistance to that, either that specific treatment or that family of treatments. And certainly that was the thinking for Taxol. If somebody had progressed on Taxol, then we were unlikely to use another taxane to treat a person. Well, this shows us that Tesa-Taxol, which is a taxane but an oral version, does seem to be effective despite progression after exposure to Taxol. And so that's important, because now we know we don't necessarily need to eliminate this treatment option if somebody's gotten Taxol in the past. So I think that's important, because this transition after somebody has gotten hormone therapy, molecular therapy, and so forth, moving on to chemotherapy can be a challenge, because you're now moving on to a treatment that has more side effects, that is IV infusion and so forth. But now with the option of Tesa-Taxol, we have another oral chemotherapy available to us. It's well tolerated. And so I think people we certainly are pleased to see another treatment option that will likely become available soon to us for metastatic hormone receptor positive breast cancer. There is earlier phase work going on, phase 1 and phase 2 trials, as I mentioned before, in terms of other treatment options, molecular therapies. There was one phase 3 trial of a molecular therapy called an AKT inhibitor. Unfortunately, that was a negative trial, but that may be a problem or a characteristic of that specific type of AKT inhibitor. There are other AKT inhibitors that are in development right now, and so we're looking forward to data from those types of molecular therapies. And just to give you some context, there is a PI3 kinase inhibitor called Alpellisiv, which is a molecular therapy that is already FDA approved. Most of us are using it in the second line space, meaning in the first line treatment, somebody's getting hormone therapy plus Cdk46 inhibitor. And then if a person has a PI3 kinase mutation in the tumor, in the second line space, most of us are using this FDA approved drug, Alpellisiv, in combination with hormone therapy like fulvestrant. But of course, the search is on for more molecular therapies before we have to turn to chemotherapy. So I would say now we have a new oral chemotherapy option, and then keep your eyes open for a new class of drugs called antibody drug conjugates. There is a drug called Sassatuzumab, which you may be familiar with. That is an antibody drug conjugate. In other words, it's a protein, an antibody, that has been fused with a chemotherapy. And I think of it as like a homing missile, basically. The protein directs the chemotherapy specifically to the cancer cell. And the idea is that it makes it more potent, so the chemotherapy finds its way directly to the cancer cell, and it helps to spare the normal cells, the healthy cells, so that you experience less side effects. Sassatuzumab is one of those antibody drug conjugates, which has recently been approved for the treatment of metastatic triple-negative breast cancer, and it is now being tested for estrogen receptor positive breast cancer. There is a large phase 3 trial that is going on right now. We're participating in it here at Memorial, and that is testing Sassatuzumab for estrogen receptor positive metastatic breast cancer after somebody has received hormone therapy. So I think lots to be hopeful for in this space. There's a lot of new molecular therapies that are coming down the pipeline, and then this new class of drugs, the antibody drug conjugates, that are also coming down the pipeline. Let me shift over in the interest of time to triple negative breast cancer. And there, Again, a lot of very exciting things coming out at San Antonio with regard to better understanding of the biology of triple-negative breast cancer, new types of therapies that are being studied. I'm sure you all have heard about immunotherapies that are showing to be very promising that we're looking at in triple-negative breast cancer. We do have an FDA-approved immunotherapy, Tesolizumab, for the treatment of triple-negative breast cancer, and that's for patients who have PD-1 or PD-L1 positive triple-negative breast cancer. That is a type of protein or molecule that is found in the microenvironment, and it's important to be specific about that because it's not necessarily found on the tumor itself. What we're learning is that the immune cells in the microenvironment, like the T cells, and other white cells in the microenvironment, are important for how the tumor responds to cancer therapy. And so what a lot of these immunotherapies are doing is they are helping to rev up the T cells and other immune cells in the microenvironment so that they can work in conjunction with the chemotherapy to be more effective at killing the cancer cells. And so Atezolizumab is currently in use typically in the first-line setting as the first treatment in combination with Abraxane, which is a type of taxane for triple-negative breast cancer. So what came out at San Antonio, of course, was the Keynote Studies, one of the Keynote trials, which is, you'll hear about a series of Keynote trials which are testing Pembrolizumab, which is another type of anti-PD-1, PD-L1 therapy for breast cancers and other cancers. We see positive data. So the combination of Pembrolizumab with chemotherapy is effective for the treatment of metastatic triple-negative breast cancer. And what's interesting there is that we're learning that the effectiveness may go beyond the classical are you positive for PD-L1 or PD-1 or not? There are other markers that we're looking at, immune markers, that may predict benefit from the addition of immunotherapy to chemotherapy. And we're also seeing that that may be effective not just for metastatic triple-negative breast cancer, but in the pre-surgical space, in the neoadjuvant space. We've seen data recently, but prior to San Antonio, that the addition of Pembrolizumab to chemotherapy in the pre-surgical space increases the rates of pathologic complete response, or in other words, shrinks the tumor more when you add on that immunotherapy. And so I think that what we're seeing now is we're going to have more options, more immunotherapy options for triple-negative breast cancer. And it's also giving us the data that we need to start testing these immunotherapy options for other types of cancers, for HER2-positive cancers, maybe for some people with hormone receptor-positive breast cancers that show a specific immune signature. There is some thought that combining immune therapies with PARP inhibitors for people with BRCA mutations may be helpful. It may actually potentiate or increase the efficacy of the immune therapy. So that's being studied as well. Some of those data were presented in poster form at San Antonio, but again, that's all very early phase right now. So we're awaiting the larger trials to be completed. But I just want to give you the sense that all of that research is going on right now. It is looking promising. So I think that we still will see a lot coming from the immunotherapy field. But currently, we do now have, we've had Atezolizumab, but we now have Pembrolizumab showing positive data in a large phase 3 trial, which is very encouraging for the treatment of triple-negative breast cancer. There's a lot of work going on with regard to PARP inhibitors, both for people who have germline BRCA mutations, but also it is being tested for people who don't have a germline BRCA mutation, and that means a mutation that you inherited or that you can pass down. That's the traditional genetic testing. But we can also look at the genes within the tumor itself. So it's possible for somebody to have a BRCA mutation in the tumor, but not in the genes that you inherited or passed down. And so we're now testing whether or not PARP inhibitors are effective for those folks, for people who have a mutation that's called a somatic BRCA mutation in the tumor, but not in the inheritable genes. So that I would say stay tuned for. I think that's an exciting area of research as well. And then that brings me to HER2 positive metastatic breast cancer. Again, a lot going on in that space, and I think to do that area justice, I would have to zoom out, not just from San Antonio, but from what's really been going on in the last year, because this has been a very, very active year for HER2 positive metastatic breast cancer. We now have 3 new therapies that have been recently approved for the treatment of HER2 positive metastatic breast cancer. Of course, there's Neratinib, which is an oral treatment. It's not a chemotherapy. It's a molecular therapy. It's a tyrosine kinase inhibitor. Neratinib in combination with capecitabine oral chemotherapy has been shown to be effective at prolonging time to disease progression or tumor growth for HER2 positive metastatic breast cancer. It may even be helpful for people who have brain metastases from HER2 positive metastatic breast cancer. Neratinib is a little bit of a challenging drug. It causes a lot of diarrhea. It has been approved by the FDA for extended use in the adjuvant setting. So after someone has completed their Herceptin, for people who don't have metastatic disease, you can take Neratinib for a year, even 2 years, to try to reduce the risk of metastasis. The problem, though, is the benefit in that setting is fairly small, very small, I should say. It's roughly less than 2% in terms of preventing or reducing the risk of developing metastatic disease, and it's a lot of diarrhea. And so I'll tell you, it's been a challenge, I think that most people reasonably decide not to do it in that setting. However, in the metastatic setting, it is now an additional treatment option, and it has been approved by the FDA now in combination with capecitabine. And as you know, our strategy in the metastatic setting is to really develop as many therapies as possible and get as much mileage out of them as well to really prolong survival. And so the more treatment options we have, the better. And so Neratinib plus capecitabine now is a treatment option for metastatic HER2 positive breast cancer, and it may be beneficial at also treating brain metastases. Still difficult in terms of the side effect profile with the diarrhea, but certainly manageable. Then we've had the approval of an antibody drug conjugate. So going back to that concept of molecularly fusing chemotherapy with a protein or antibody that targets the chemotherapy to the cancer cell. And so the Daiichi compound, which is the drug company's Daiichi, the drug is known as Enhertu, was approved in the last few months by the FDA for the treatment of HER2 positive metastatic breast cancer. That is an antibody drug conjugate, and that has been significantly effective in prolonging progression-free survival, and that is a fairly well-tolerated antibody drug conjugate. Again, because it's serving as a homing missile for the chemotherapy, it's reducing some of the toxicities or the side effects to our normal cells. So that's been a very, in my opinion, a very effective new therapy that's been approved this year for the treatment of HER2-positive metastatic breast cancer. The thing to keep in mind about that therapy is the major risk from that therapy is it can cause an inflammation of the lungs in roughly 15% of people who are treated with it. And that's called a pneumonitis. And so many oncologists are checking pulmonary function testing or watching your lungs closely. Certainly if you develop a cough, if you're being treated with Enhertu, you should let your oncologist know right away to make sure that that side effect is not developing. The third treatment option that was recently approved by the FDA is Tucatinib, or Tukysa is the brand name, and that's a drug by Seattle Genetics. Tucatinib is also a tyrosine kinase inhibitor, just like Neratinib, but it's a lot more specific. Neratinib is considered to be a pan-HER tyrosine kinase inhibitor. So as you may know, there are different HER molecules, not just HER2. There's HER1, HER2, HER3, HER4, and so on. Neratinib kind of hits all of them. Tucatinib hits specifically HER2. And we think that that's beneficial because it's very well tolerated. It's got a lot fewer side effects. There is potential for diarrhea, but it's a lot less. There's less skin toxicity and so forth because it's really targeting specifically HER2. So tucatinib in combination with capecitabine and Herceptin has been approved for the treatment of metastatic HER2-positive breast cancer, significantly prolongs progression-free survival, and very interestingly, has been shown to be very effective, very helpful for brain metastases. In fact, it prolongs progression-free survival in the brain as well. And in other words, it helps to reduce the risk of existing brain metastases from growing, and it might even reduce the risk of developing brain metastases in the first place. So that's a very exciting new treatment option, and there will be a lot of continuing research that is being done on all of those new treatment options as we learn more and get more experience with those treatments. There are a lot of other drugs that are currently in the pipeline that are not ready for prime time yet. There are some of the ones that are probably piquing a lot of people's interests are new antibody drug conjugates like Enhertu, new tyrosine kinase inhibitors like tucatinib are coming down the pipeline, and new types of antibodies. So there are bispecific antibodies. These are antibodies that target not just HER2, but maybe HER2 and HER3 or others. And it's essentially a dual inhibition approach. So there are drugs, bispecific antibodies that are currently in development. Probably the bispecific antibody that's the furthest in development is by a company called Zymeworks. And so they continue to present updated data at these conferences as well. So stay tuned for more data in terms of the efficacy of bispecific antibodies. Margetuximab, for example, is another type of antibody. It's not a bispecific antibody, it's a new type of antibody that may be helpful. With data that has been presented by Dr. Rugo and others at ASCO at San Antonio. And I have to tell you that my own personal opinion is I wasn't really impressed by the magnitude of benefit that was shown with margetuximab. It was fairly small, and especially part of the reason why I wanted to outline to you all of the other treatments that have been recently approved for the treatment of HER2-positive breast cancer. I think that now that we've got several other treatment options with dramatically better, of course, you never want to compare drugs unless they've directly been compared in a clinical trial, but I think we also have to be practical. And when you look at the magnitude of benefit for some of these recently approved drugs for HER2-positive metastatic breast cancer, you see pretty dramatic benefit from drugs like tucatinib and Enhertu. I wasn't terribly impressed by what we saw with margetuximab. However, there was a benefit, so we can't minimize that. And also, I think it's an evolving space because there's also data to suggest that the response to margetuximab may depend on the biology of the tumor. There is some heterogeneity in how HER2 is expressed. In other words, the way that HER2 is expressed for some people's breast cancer is different than how it is expressed for other people with HER2-positive metastatic breast cancer. And that has to do with the types of genes that are turned on or turned off in the tumor. And that can impact the affinity or the stickiness of how well the anti-HER2 antibody binds to the HER2 receptor. If you have a HER2 receptor that's not very sticky, then the antibody is just going to fall off and it may not be effective. But if you have a HER2 receptor that's very sticky, and I apologize for being so reductionist about it, but it helps me to think about these drugs, then the antibody will bind and adhere and may be more efficacious. And so we're starting to learn that that's playing a role in how people respond to margetuximab. On top of it, I talked earlier about the immune microenvironment for triple-negative breast cancer. Well, that's also important for HER2-positive breast cancer. And so for HER2-positive breast cancer, the T cells that are present and other immune cell infiltrates in the tumor microenvironment may also play a role in how a person responds, or how a tumor responds, I should say, to margetuximab. And so I have not closed the door on that treatment option. There is a benefit, it's small, and perhaps the benefit may be greater, it might even be profound, when we identify the right immune signature and the right affinity signature, the stickiness signature. And if we can identify the people with those kinds of signatures that predispose them to respond well to margetuximab, then this might turn out to be a really good treatment option for those people. So there's a lot of research that's being done to try to elucidate that. Okay, we're getting close to time, and I've already exceeded my own outline, my own restrictions, so apologies for that. I do want to leave time for questions and answers. I'm just going to say really quickly about lifestyle research. There was a lot that was presented. You might have seen a big trial was presented, a French trial, which showed that a low glycemic diet, in other words, a diet that is used to prevent or treat diabetes, was helpful for reducing the risk of developing breast cancer in the first place, but also for people who are diagnosed with breast cancer. There was another large trial that showed that in women who adhered to a diet, the diabetes prevention program diet, they had prolonged survival. They lived longer after a breast cancer diagnosis. And so take a look. The diabetes prevention program is widely available. You can Google it and see what that diet consists of. You can actually, many local community centers like the YMCA offer courses on how to implement the diabetes prevention program in your own life. The Live Strong program is a version of the diabetes prevention program that is also available at many centers locally. So you can find these resources online, and you can certainly engage in those programs. There are a lot of studies where we at Memorial are currently testing exercise in combination with Cdk46 inhibitors and hormone therapy for people with metastatic disease. That trial is ongoing right now. We're testing different diets. We have a trial of a plant-based diet. We have a trial of a ketogenic diet that's coming up. Right now, I'm not endorsing any of those diets. There's a lot of information out there that's being talked about, but most of that is not based on randomized prospective trials. And all of the drug data that I just outlined to you is randomized prospective trials. And in my own opinion, I think we should be applying the same vigor of research to diet and exercise trials, which is what we're doing. We just don't have that data yet. And that's why I am agnostic. In other words, I'm unbiased. I don't particularly recommend a diet in the metastatic setting until we have the data. We're testing, like I said, keto, we're testing plant-based. We'll see, hopefully we'll have recommendations soon. I think it will depend on the biology and the genomics of the tumor. But in general, I do recommend a metabolically healthy diet, which is either a diabetes prevention diet or a diet that's high in fiber and fruits and vegetables. So I will end there, and there was a lot to talk about, but I hope there was some semblance of organization there. I hope you found this helpful, and let's go ahead and open it up to questions. Thank you.
Thank you, Dr. Iyengar. You presented a lot of information, all very good information, and you presented it in a way that was easy to understand, so thank you so much for that. We do have a few questions. Let's see here. So as you mentioned, there have been a couple of drugs recently that seem to be effective for brain mets. Is there any research underway for treating or hopefully maybe even ideally preventing leptomeningeal disease?
It's a great question. So for those of you that don't know, leptomeningeal disease is when the cancer has gotten into the lining of the brain and the spinal cord, and that can be tricky to treat because you're not treating directly a tumor, but you're detecting like a spread out cancer amongst the lining. And so radiation, for example, can be challenging to use because you'd have to radiate a lot of area, which can of course cause side effects. Unfortunately, a lot of these drugs that I just outlined, while they included people with brain metastases, they excluded people with leptomeningeal disease. So I can't comment on the efficacy of these drugs for people with leptomeningeal disease. However, with that being said, there are reasons to believe that theoretically these recent approvals should be effective for leptomeningeal disease as well. I think time will tell as we gain more experience using these new therapies. Certainly, if I have somebody who has leptomeningeal disease and we've gone down the standard treatment options, then this would be something like tucatinib, for example, is something that I would consider trying. Now, it's certainly not based on data, it's off-label, but it's something I would think about. There are earlier phase trials that are looking at treatments for leptomeningeal disease. Many of them are combination treatments with radiation, for example. And so there's a lot of earlier phase work that's going on in this setting. So hopefully we'll have something more tangible to offer in the near future.
Thank you. And then someone was asking if there's any news on the Emerald trial with fulvestrant versus the oral version of fulvestrant.
Yeah, so that's something that, so there's no news yet, but that is something that we're watching closely. There are a couple of oral SERDs like fulvestrant that are, well, fulvestrant is not oral, but it is a SERD, but there are a couple oral versions of it that are in development right now that are being tested. One of the promising things about that class of oral SERDs, just like Tesotaxil, the oral taxane, is that it's now starting to become, I don't want to say clear, but the possibility has surfaced that these oral SERDs may be effective even after somebody's gotten fulvestrant. And so if that's the case, that would be great because that would add yet another treatment option to our toolbox for metastatic breast cancer. So no news, big news yet on that trial, but promising.
So our friend Shirley is asking, should all MBC patients undergo genetic testing? The topic was debated at SABCS by 2 oncologists. Why is this still being debated? Why are we still asking this question?
Thanks, Shirley. Hi, Shirley. That's a great question. And I'm sure, as you probably know, I'm biased because the oncologist who debated for it is somebody I work with. And so, you know, I think it's challenging. In full disclosure, I do it. I test all of my patients, certainly with metastatic breast cancer, for it. I think the reason that people give, so it's hard for me to actually argue why we shouldn't do it, but the reason why that people don't do it is because, let's say I have somebody who has metastatic breast cancer, and we do genetic testing, and you know she's got ER positive metastatic breast cancer, and she has a BRCA mutation. The question then becomes, do you use a PARP inhibitor? Where do you sequence it when we've got all of these other great therapies for ER positive breast cancer? Do you use it in combination with these treatments? And you know, I'm in fact, I actually just had a lovely patient of mine this morning who we had this very conversation, who we did the genetic testing and we found she has a BRCA mutation, she's ER positive. We're using molecular therapies, hormone therapies. So I think that the people that are not excited about doing it are waiting. I think that's what they're waiting for data. There are trials that are testing combinations and sequencing and all of that to show that there is clinical action that can be taken. When you have the benefit of being at a research center like this, we can take actions. We have trials. We have the benefit of knowledge from those trials, the ongoing science, where I personally feel like that information, that genetic information, is useful. But certainly for somebody who you know, maybe lives in an area that is not served by an active academic center, and can only use on-label approved therapies, then getting that information may not help to direct that kind of treatment approach. But I'm biased, and I think it can be helpful.
So we're just about out of time. I'm just going to squeeze in one more question. Any specific lobular research in either treatment or imaging?
Yeah, it's a great question. So there's a lot of biology research that's being done. You know, there's nothing that I can think of off the top of my head that was major at San Antonio, but there are studies being done with regards to imaging using specific biologic tracers, like tracers that target the estrogen receptor, for example, to try to see if we can improve the sensitivity of picking up lobular disease on radiographic. As I'm sure you know, picking up lobular disease on on radiology tests is challenging, both because of the way that lobular grows and the pattern in which it grows. And so there is work being done in improving radiographic techniques by adding these kind of biologic tracers. I should also add that, and I'm sure many of you know this and could tell me about this, but I think for those of you that are involved in the patient side research with regards to helping us understand patterns of lobular carcinoma, that's really important. And that really brings up, I hope people here know about MBC Connect, which is an app that Shirley is here. She could tell you all about it better than I could, but I have been involved. I've had the privilege of being involved in looking at this from a scientific and data standpoint. We think there's a lot that the scientific community can learn from people who are diagnosed with metastatic breast cancer. And so this is a digital app or platform that allows you to put in your information, but it also helps people in terms of connecting them with one another, but also helping you with clinical trial matching and identifying other resources that may be available to you. There is integration with other research initiatives like questionnaires and understanding lobular carcinoma better, for example. So I would certainly say check out MBC Connect if you haven't already.
Thank you so much, Dr. Eingar. You have been terrific as usual. We so appreciate your time and your expertise. And again, everyone, thank you so much for joining. Please visit our website, sharecancersupport.org, and also MBC Connect at the mbcalliance.org website. Thank you so much. Thanks, everyone. Have a great and safe holiday season. Thank you.